Hello friends. So today I am going to talk about cord prolapse, and there are usually three clinical types of abnormal descent of the umbilical cord by the side of the presenting part, and all are placed under the heading of the cord prolapse. And the first one is occult prolapse. Here the cord is placed by the side of the presenting part and it is not felt by the finger on the internal examination, and it could be seen on ultrasonography or during cesarean section. And the next one is we have the cord or funic presentation. The cord is slipped down below the presenting part and it is felt lying in the intact bag of the membrane. And we have thirdly we have the frank cord prolapse, where the cord is lying inside the vagina or outside the vulva following rupture of membrane. And this is a picture of frank cord prolapse. The incidence of cord prolapse varies widely from 0.5% in cephalic presentation to 20% in transverse lie, and it is mostly confined to the paraswomen. And the etiology, anything which interferes with the perfect adaptation of the presenting part to the lower uterine segment may favor cord prolapse. Too often, more than one factor operates. The following are the associated factors like the malpresentation, the most common being transverse 5 to 10%, and breach 3%, especially with the flexed leg or footling and compound presentation. And the next ones we have the contracted pelvis, prematurity, the twins, hydramnios, placental factors like a minor degree placenta previa with marginal insertion of the cord or long cord. Seventh one is we have the prematurity, iatrogenic procedure related, that is low rupture of membrane, manual rotation of the head, or um, external cephalic version or internal podalic version. All this procedure related thing, there can be cord prolapse, and the stabilizing induction can cause cord prolapse. Diagnosis: the occult prolapse, it is difficult to diagnose, and the possibility should be suspected if there is persistence of the variable deceleration, bradycardia of the fetal heart rate pattern, and degrees detected on continuous electronic fetal monitoring. And the intrapartum ultrasonography IUSC is very informative. The cord presentation is diagnosis made by feeling the pulsation of the cord through the intact membrane, and the cord prolapse is diagnosed by palpating directly by the fingers, and its pulsation can be felt if the fetus is alive. And the cord pulsation may cease during uterine contraction, which however returns after the contraction passes off. And temptation to pull down the loop for visualization or unnecessary handling is to be avoided to prevent vasospasm. And the prompt ultra USG Doppler study for the cardiac function or auscultation for a fetal heart sounds to be done for fetal assessment. And the prognosis, talking about prognosis of cord prolapse, the umbilical cord prolapse result in cord compression, and this happens as the cord lies between the presenting part and the pelvic inlet, cervix, or the vaginal wall. The umbilical cord compression reduces fetal circulation, and depending upon the duration and severity of compression, there is either fetal hypoxia, brain damage, or even death. And apart from cord compression, there is vasospasm of cord vessel due to irritation and the temperature variance when the cord comes out. The perinatal mortality associated with all cases of overt umbilical cord prolapse is about 20%, and prognosis for intrapartum cord prolapse is improved. And overall prognosis depends on the gestational age, degree, duration, and severity of cord compression. And when the prolapse cord occlusion has occurred for more than or equal to 5 minutes, or intermittent or partial occlusion has occurred over a prolonged period, the fetal damage or death may occur. And if the delivery is completed within 10 to 30 minutes, the fetal mortality can be reduced to 5 to 10%. And the overall mortality is about 15 to 50% in the cord prolapse. And the maternal risks are incidental due to emergency operative delivery, especially through the vaginal route, and operative delivery involves the risk of anesthesia, blood loss, and infection. The patient with malpresentation or poorly applied cephalic presentation should be considered as high risk for cord prolapse. For prevention and early detection, the patient with malpresentation or poorly applied cephalic presentation should be considered as high risk for cord prolapse, and USG examination may be helpful to determine fetal lie and cord position. Artificial rupture of membrane should be avoided until the presenting part is well applied to the cervix, and the pelvic examination should be a routine to rule out cord prolapse following spontaneous rupture of membrane. And careful kneading of the membrane and slow release of amniotic fluid can be performed until the presenting part is fixed against the cervix. The pelvic examination should be routine to rule out cord prolapse following spontaneous rupture of membrane, and the careful needling of the membrane and release of amniotic fluid can be performed until the presenting part is fixed against the cervix. Now we will talk about management of cord prolapse. The cord in cord presentation, the aim is to preserve the membrane and to expedite the delivery. Once the diagnosis is made, no attempt should be made to replace the cord, as it is only ineffective, but membrane inevitably rupture, leading to prolapse of the cord. And if immediate vaginal delivery is not possible, then the cesarean section is best method of delivery. During the time of preparing the patient for operative delivery, she is kept in exaggerated Sims position. And on rare occasion is when a fetus with longitudinal lie, good uterine contraction, cervix nearly full dilated and without any evidence of fetal distress. And patient should be placed in left lateral maternal position, and oxygen is administered and electronic fetal monitoring is started. And with full dilatation of cervix, delivery is completed by forceps, and alternatively category 1 cesarean section is done. So management protocol of the cord prolapse is determined by whether the baby is living or dead. It is determined by the viability of baby and degree of dilatation of the cervix. If the baby is living, the definitive treatment includes: one is the cesarean delivery is the best treatment when the baby is sufficiently mature and alive. Just prior to making the abdominal incision, the fetal heart rate should be auscultated once more to avoid unnecessary section on dead baby. And this is the best treatment of choice, immediately cesarean delivery. And the immediate safe vaginal delivery is possible if the head is engaged. Delivery is to be completed by forceps, and ventos may not be ideal in such circumstances, as it takes a longer time. And vaginal delivery is allowed when the fetus is pre-viable or dead. There, if baby is dead, then the confirm with ultrasound and wait for spontaneous delivery for the dead baby. And again, in the live baby, we can do vaginal delivery, but if everything is safe, the head is engaged and all those things. And breast extraction in the expert hand only. And immediate vaginal delivery is not possible, then the one is we have to do the first aid management. The aim is to pressure on the cord till such time when the patient is prepared for assisted delivery or reaches an equipped hospital. So if an oxytocin infusion is on, this should be stopped. At this time, intravenous fluid and oxygen by face mask is given. And the bladder filling is to done to raise the presenting part of the compressed cord until till such time that the patient has delivered either by CS or vaginally. And the bladder is filled with 400 to 750 ml of normal saline with a Foley's catheter, and balloon is inflated and the catheter is clamped, and the bladder is emptied before cesarean delivery. The bladder filling is done to raise the presenting part of the compressed cord till the time the patient is delivered. And we have to lift the presenting part of the cord by gloved finger introduced into the vagina. The finger should be placed inside vagina till effective treatment is instituted. Nextly, we have the posture treatment. Exaggerated or elevated Sims position with pillow or wedge under the hip or thigh can be given. Trendelenburg or knee chest position has been traditionally mentioned, but may be tiring and irksome to some patient. And to replace the cord into vagina to minimize the vasospasm due to irritation. And if the baby is dead, the labor is allowed to proceed awaiting spontaneous delivery. So that was all about cord prolapse management. Thank you. Now have a good day. Now we will meet again in next video on obstetrics. Thank you.